Thanks so much, Kathy, for that introduction. I'm really excited to start our day off today because I think it's going to be quite an inspiring day. So I'm going to sort of set the scene by talking about the social determinants of health and determinants of food and eating. I'm a public health nutritionist and also a social scientist and sociologist. So I've long been interested in conducted research about social and socioeconomic factors that influence the diet of young people, their families, and the professionals who look after or provide for them, whether that's in health or social care settings, at home, in the community, or within schools. So I'm going to start by talking about the definition of what we mean by social determinants of health and how such determinants might influence children accessing or needing secondary care, before moving on to talk about social determinants and how they relate to food and eating practices. And I'm using the term practices quite deliberately rather than behaviour. Behaviour can tend to be seen to be an action, something we do, some decision that we make to eat something or purchase something. But when we talk about practices, I think it helps more explicitly ensure that we consider that broader range of factors: values, beliefs, resources, technologies, policies, etc. So I'm going to talk about some of the evidence regarding social determinants of food and eating practices. And I'm going to end with a couple of tensions as well as several really good opportunities, I think, as we all move forward and help craft this vision for Cambridge Children's in relation to food. So next slide, Anna. Thank you to Anna for doing the slides today. Oh, that's not come up how it should do. Have we lost all of the formatting? Next one. If not, we'll just move on anyway if the content's there, but that's not all of it. It might mean we've lost all the images, so sorry, they did look really nice. But so in terms of the social determinants of health, these are widely accepted as influencing health, particularly during periods of transition. So of course that's really important when we're thinking about child and adolescent development. So the conditions into which we're all born, grow up, study, work, and grow old interact with a wider set of factors and systems and shape our everyday lives. And social determinants of health also, sadly, shape inequalities and inequity in health outcomes. The lower your socioeconomic position, the worse health you're likely to have across many indicators. But inequalities are avoidable and preventable differences in health status among population groups, which is important that we take account of. So on the screen is an adapted list from the World Health Organization's definition of social determinants. So this includes income, educational attainment and experience, unemployment and job insecurity, working life conditions if you're in work, food insecurity, housing and basic amenities, early childhood development, and social inclusion and social capital. Social determinants are really challenging to address. Those factors on the screen are obviously so broad-reaching. So interventions that might seem to be effective overall are often found to compound or even worsen health inequalities. And this might be, for example, that people from a lower socioeconomic position are less able to engage with an intervention, or it might not appeal to them. This really can't be ignored. And social determinants might influence which children are admitted to hospital or require treatment in the first place, how well such children and families fare whilst being part of the hospital or healthcare system, and how well they recover when they're back home. And it's factors that include things like poor housing, whether families are living in damp, overcrowded, unsafe housing, whether it's temporary or unstable, or they don't have anywhere to call home. Factors like transport and whether households have access to a car or reliable and affordable public transport to get to healthcare appointments. Parents' education is important and their understanding of a condition and its treatment, as well as their employment and income, the need to be at work and not actually be able to take time off and able to take children to their appointments. And the social capital of the family, the sort of broader social bonding and bridging networks that families need to turn on when times are quite tough. Next slide, please. So children who live in more deprived areas, we've got the pictures back, lovely. Children in more deprived areas are more likely to be exposed to avoidable risks before birth even, and to get off to a less healthy start and to experience poor outcomes by the time they start school compared with children who live in more affluent areas. Health inequalities are seen across all of the indicators on the screen that Public Health England reported on in 2018. For children, inequality starts early and can persist right throughout a child's life. Next slide, please. So in terms of food security as a social determinant, we tend to define food insecurity as the inability to consume an adequate quality or sufficient quantity of food in socially acceptable ways, or the uncertainty that one will be able to do so. Food and eating practices in contemporary Britain are really complex. There's something about our food system, as well as the UK context, that means on the one hand, we have a problem with childhood obesity, whilst also showing that some people don't get enough to eat and become malnourished and hungry. Losing weight is bad for some people, but good for others. Cakes can be eaten if you're lucky, in inverted commas, to be a healthy weight, but not if you're overweight. You can shop for food that's limited in fat, sugar, and salt content if you've got the means to do so. But if you go to a food bank, you have little agency about what food is actually made available to you. So your experience compared to mine will be very different depending on your background, education, your job, your income, etc. Social structures and experiences are important, and they matter, and they help shape how markets respond to so-called consumer demand, as well as interacting with all the interrelated contexts and settings in hospitals, schools, workplaces, and so on. Social, economic, and environmental structures inform and reflect the world around us. So foodscapes are complex and they're challenging, and they certainly challenge us within public health, which is the perspective I'm coming from. The public even is not always convinced that anyone in a rich country like ours can truly be hungry or malnourished, and they almost always blame parents for giving in to children, feeding them fast food and sugary drinks with little thought to their health. But children, young people and families can only eat well in a system that gives them a fair environment in which to practice. So the more that we understand the socially constructed nature of so-called food choice, the better we can support people in our region to eat well. Next slide, please. So food security in terms of being a social determinant covers things like the social acceptability of food, the availability of food and its commercial determinants, the availability of the resources you need to prepare and consume food at home or other settings, the affordability of food, diet quality, and rates of obesity. And I'm going to go through these now. Next slide, please. So in terms of social acceptability, food is central to who we all are, biologically, psychologically, socially. The food we take in when we eat it becomes part of us in the true sense of being ingested or nourishing us, but it's a really key part of our identity. So whilst we all have physiological needs that might drive our hunger, the cultural and social imperative to eat in particular ways is embedded in our identity as much as whether our diets are full of nutritious fruit and vegetables or food high in fat, sugar, or salt. It's impossible to untangle the material aspects of a food from the social desire to eat some foods and not others. Food and eating are about sociality, commensality, and about expressing care. And you're going to see that in the Children's Network video this morning. The way we provide food for other people and the fact that we like to eat with people we care about. In one of our studies, in fact, in all of the studies I've ever conducted with young people, food is quite often, or almost always actually, a secondary concern to the expression of kinship and friendship and care through eating with friends, family, and others. When socioeconomic deprivation is an issue for young people, the importance of caring from others becomes really manifest in the research we do through seeing that young people ensure their peers have adequate food to eat through sharing and going without food themselves if necessary. Social availability and acceptability becomes an issue of equality, diversity, and inclusion, and an issue of food and youth justice. It's not sufficient to offer nutritious food if it's not socially acceptable to some groups. Social acceptability of food encompasses the impact of all the other social determinants I've talked about and is at the heart of our food and eating identity. In countries like the UK, nutrition and health fight with hedonism, that pleasure we get from food and eating. We find that really complex in the UK. In other countries, such as Spain or Italy, there's less of a fight. People are quite happy in Mediterranean countries where pleasure takes precedence and concerns about health or nutrition are subsumed within that pleasurable nature of eating food. We don't find that as easy. But our knowledge, values, beliefs, and the norms and symbolic meanings of why we eat what we eat collide into a display of the intersection between people, objects, and settings. This is really powerful in terms of a factor when designing a food service, particularly in an institutional setting where there's often an imbalance in terms of who decides what food is available. But young people in schools repeatedly tell us they don't want to eat a meal, however you might define that. They want to eat quite often the least amount of food as quickly as possible to enable them to maximize time spent with their friends. They want flexibility in terms of the food that's on offer. Or quite often in schools, if they're allowed to buy chips, they have to buy it with another item. That doesn't mean meet the social requirements of what they want. They want to buy fruit and salad, but not if it's soggy in a container that's sat in a vending machine for several days, which we've seen quite often. And young people really don't like being misled with advertising and pricing and marketing when it comes to the healthiness of food that's available to them. Children and young people are really canny consumers, and they want to be consulted and part of the decisions about the food on offer. Next slide, please. In terms of the availability of food, this partly relates to commercial factors which are interwoven with the social determinants. So, for example, the density of food outlets in an area is different in a socioeconomically deprived part of our region compared to a more affluent area. This impacts what we all buy and consume. It impacts on the opportunities we all have for eating outside the home, and it impacts on the advertising that we all view and consume daily, whether you're walking to school, work, or a hospital. It's all part of our food system. It can even influence whether young people and families feel that food outlets are for people like them. We've found this quite often in our research. There are intrinsic and intangible barriers surrounding where people shop for food that's acceptable to them. It's estimated that the number of food outlets in England increased by 79% from 1980 to the year 2000, 79% over that 20-year period. And that's likely to have changed substantially since then too. Food outlets are everywhere. And the World Health Organization states that the private sector influences social, physical, and cultural environments through supply chains, labor conditions, product design, packaging, preference shaping, and other factors. So commercial determinants affect everyone, but young people are especially at risk, and unhealthy commodities worsen or amplify existing economic, social, and racial inequities. Next slide, please. In terms of food preparation resources, it's very often reported, certainly in sort of mass media, that people don't cook these days. They don't have the skills to cook. They're less likely to spend time cooking with fresh ingredients than compared with earlier decades. This is not necessarily the case. And the relationship between cooking and dietary health is still not well understood, though we know that that determinants, including your sex, employment status, social relationships, and ethnicity impact on the amount of home cooking households undertake. Many families have shared kitchens. They don't have an oven. They don't have a microwave. They may not have a kettle. Their facilities are few, or even if they have such items, they can't afford to use the electricity or the gas in order to work them. So experiences of food preparation are not a socially neutral issue. Next slide, please, Anna. In terms of affordability, this not only relates to the actual price of food, but the value that food items are perceived to have. And our research always shows that young people are keenly aware of their parents' income and how much it costs to feed the family. Many young people living in a family of low socioeconomic position don't want their parents to feel under pressure to pay out more than is needed to look after them and their siblings when it comes to food provisioning. Research consistently shows as well that parents will feed their children and go without food themselves when money is tight. The research we conducted for the ARC during the pandemic in the east of England highlighted that professionals and volunteers supporting families with school-aged children noticed that diet and health became deprioritised during the pandemic as a way of coping. And going without food regularly, it goes without saying, is not good for anyone's physical or mental health. Next slide, please. In terms of diet quality, evidence suggests that family affluence, things like owning a car, children having their own bedroom or computer, is related to the consumption of fruit and vegetables, sugary drinks, and whether young people eat breakfast. And young people in low-income families are more frequently consuming takeaways, all of which impacts on the quality of someone's diet. The National Food Strategy is the government-commissioned independent review of the UK food system that was conducted over the last couple of years and led by Henry Dimbleby. Part 2 of the strategy, which was published last year, highlighted 4 significant changes that will be required in the next 10 years if we're to meet government recommendations on diet and land use. We need a 30% increase in fruit and vegetable consumption to bring us in line with the Eat Well recommendation to eat 5 items of fruit and vegetables a day. We need a 50% increase in fibre consumption to bring us in line with recommendations, and a 25% reduction in foods high in fat, sugar and salt to meet the targets. We also need a 30% reduction in meat consumption to meet the 5th carbon budget target and the 30 by 30 nature commitment. That's to address 30% of the global oceans by the year 2030. There's a lot to do. Next slide, please. In terms of obesity, the burden of obesity is falling hardest on children in low-income areas across the country. Children living in the poorest areas of England are 4 times more likely than children from the richest areas to be severely obese at the age of 4 or 5 when they start primary school. When they leave primary school, age 11, they're 5 times more likely to be severely obese than their richer peers. And obesity in childhood tracks through to adulthood quite often. And it's been estimated that every unit of body mass index gained by an individual adds £16 to the annual healthcare budget. That's £16 for every individual who gains 1 unit of BMI. And children with excess weight suffer stigma and shame, often have poor self-esteem, poor mental health, and greater likelihood that they won't engage in physical activity. There are multiple reasons why obesity is a social determinant, and given it's often a social norm within some communities, attempts to tackle it has to take account of the social construction of the condition. Parents who buy food high in fat, sugar and salt don't do so because they don't care about its impact on their child's health. Our research shows us they buy it because it saves money. They know children will eat it. They know their children will value it, and it prevents food waste. Buying takeaway food means not having to use electricity to cook, also saving money and preventing food waste. These are complex issues where social practices can help us to understand the motivation and meaning between eating food that's likely to lead to weight gain when consumed in excess. A consultation we conducted within the ARC with young people living in Stevenage highlighted that many didn't go out on their bikes, for example, because of the experience or the fear of having their bike stolen. Many didn't seek out the places where physical activities could be undertaken with others because these places weren't in a good condition or because there was a fear of being a target of physical abuse. And many young people couldn't understand why bus tickets had discounts printed on them to purchase burgers when really they wanted access to fruit and vegetables. So the lived social and spatial experiences of obesity tell us a lot about how to approach the management of excess weight as a social issue. So I'm going to move on now to talk about some of the tensions and opportunities that we have so that we can take account of social determinants as we create this vision for food with care. Next slide, please. Firstly, in terms of tensions, our next bullet point as well, please. Thank you. Having a chronic condition or being treated or being in hospital can create episodes of biographical disruption, a life being interrupted, our social networks disrupted, and uncertain futures for a period. Now, we can see this as a teachable moment and a chance to improve the diet of the young people and the families coming to the Cambridge Children's. But we really need to think through how appropriate that is, or whether the hospital needs to concentrate on ensuring children and families are comfortable and can eat well according to their typical social norms. And you're going to see this in the film that you'll see later this morning. Are we only interested in the period when children are in the healthcare system, or are we interested in their everyday lives right across the life course? Unlike in schools, food is universally provided to all children when they're an inpatient. So that's an opportunity to change food and eating practices. But it's crucial to think about these broader determinants, not only for that immediate issue of food and eating behaviour. So there's a tension, but there's an opportunity for Cambridge Children's to think about biographical disruption and to do something innovative that has a lasting and positive impact that allows children and families to restore order to their lives in a way that also improves their diet, health and well-being. Next bullet point, please. In terms of the very many special and additional needs and the complexity of conditions of families, not just the children who might be coming to Cambridge Children's, as well as the diversity of populations we have across the region, will also challenge us as we make this step forward to food with care. We want to make eating well universally acceptable and accessible, but is that possible when patients and families have different conditions and different social norms? This is something I want us to address really sensitively. Next slide, please. In terms of opportunities, whole and complex systems approaches within public health are advocated for issues such as addressing inequalities in obesity and are often being adopted in different local authority areas across England and the rest of the UK at the moment. The next bullets, please. The bullet points on the slide are some of the essential elements of a whole systems approach. We need multiple levers to be applied, and partnership working is absolutely essential to achieve change when it's complex. This absolutely has to involve the parity of involvement of local communities, children, adults, organisations, as well as the many healthcare professionals who are working with them. It's acknowledged that impact can take many years when you have to take a whole systems approach. But given that Cambridge Children's is at such an early stage of development, again, we have a real opportunity here to do something differently. Whole and complex systems approaches move away from a low risk approach when we only think about the individuals and getting individuals to change. We want to take an approach that's actually more complex and harder to achieve, but is much more likely to result in an impact at population level across our region. Because the less that individuals have to do themselves to eat well through creating the right structures and addressing determinants, the more likely it is that we're going to see universal impact on health and well-being from improving food and eating practices. Next slide, please. I won't go through this in too much detail, but this is an example taken from Hertfordshire County Council, where we are taking a whole systems approach to address obesity. So note the arrows across the top to do with the speed of results, but also the rate of impact or the extent of impact. The areas in blue are potential areas. This is specific to obesity, but can be applied more broadly to food systems. So the areas in blue relate to potential interventions, areas for prevention, and the area in orange is potential intervention. And the enabling factors at the bottom, I think, are really helpful in terms of how we might think about food with care through learning and research, maximising the use of digital technologies, and absolutely incorporating behavioural and social science insights. I'll put this in the slide so that you can have a look at it when you get the copy. Next bullet, please, Anna, thank you. I also want us to think about hospitals as being anchor organisations. Anchor organisations means taking a place-based approach to consider and address social determinants. A hospital is a large and stable organisation. It therefore acts as an anchor within the local population because it's rooted understanding their needs. Hospitals can wield influence simply by existing, but we can be more ambitious and utilise the scale and influence on the health and well-being of the workforce and local populations through integrating food across all aspects of the hospital. Next bullet. Oh, we've got whole school approaches there. I was going to say we need to look at whole school approaches where in some schools across the country where they take an absolutely integrated approach thinking about the importance of food, they really can maximise success and help to address inequalities within an area. So that's already being done. That's another area where we can turn and look to for inspiration. Given the National Food Strategy calls for reductions and reformulations in terms of fat, sugar and salt within the next 10 years, again, this is something we can do right from the start where we are now when thinking about Cambridge Children's. Next bullet, thank you. The National Food Strategy also calls for a community eat well initiative whereby healthy food is prescribed. How can Cambridge Children's use food as part of an underpinning prevention strategy to promote better health? How can Cambridge Children's, for example, use the Healthy Start scheme and enhance it, ensuring pregnant women are able to access healthier food for themselves and their family? What is the role of the new hospital in the prevention agenda? There's a really massive opportunity to do something different and address inequalities and the social determinants of health. Next bullet. The youth consultation that was carried out, Your Future, Your Food, with the Food Foundation as part of the National Food Strategy consultation, highlighted that young people want the social determinants of food and eating addressed by the adults who care and provide for them. And young people's recommendations related to education, the environment, and equality, and we can draw inspiration from this. This includes taking steps to ensure a healthy and sustainable diet is affordable and accessible by all children and young people in the region, that wealth inequality is tackled, and that the pricing of healthier food items is considered, so that the disparity in access to good food is addressed across all neighbourhoods. So, final slide. Thank you, Anna. As we think, and I want you to think as you go through the day today about what good looks like when it comes to food with care, consider the words of a parent like Lucy on the screen. Lucy was one of the participants in our ARC study of food inequalities during the pandemic. We all need to think about the ways that the different elements of food and eating practices from a social and socioeconomic perspective are going to impact on the way that foodscapes evolve at Cambridge Children's. How do these relate to the physical infrastructure, to the hospital as a workspace with a really important and influential workforce? And how can we integrate young people's perspectives and those of the wider family? And how do we plan the best delivery of a service? Social practices and social determinants are relevant to all of these things. How are we going to integrate them for the best food with care experience? I think we're all going to get lots of ideas today. Thanks very much. You can stop sharing, Anna.
Thank you so much, Wendy. That was a fascinating talk and also very grounding. I suppose I realize our task is much bigger than we thought it was. I think for many people on the call, particularly those of us who are clinical, we're very used to individual interventions for individual patients, and actually switching over to this idea about whole populations and the hugely complex factors that you outlined that feed into this feels a little bit overwhelming. However, I love the fact that your talk ends on a positive note that gives us a little bit of a roadmap to explore. And I can see that we're going to have you talking about whole and complex system approaches probably repeatedly. The other thing it highlights for me is the necessity, your point about weaving this through every element of our development of the hospital. So thinking about the school, thinking about our digital strategy, and things like our play and nature and arts program. All these things are actually very important in this. But the idea that if we're to be very effective as an anchor organization, how do we actually spread beyond the hospital walls is a real challenge to us. But we're up for a challenge.
Good.
So,
yeah.
Do we have any questions from anyone at all? I'm just trying to look in the chat here. I think everyone is very quiet, actually. Okay. So this is a comment from Debs. My parent experience of a child on chemo was very complex. When your child is sick, you want them to be fed the best food possible. We had Mick on the ward cooking only fast food related products. Tom was peg fed and only really digging and asking, did I realize that I could blend my own food and feed that through the peg? I apologize, Debs, if I've read that wrong. Yes, Debs, do you want to actually say this yourself? If you just put on your mic.
I'm here. I don't know how to put my thing. Yeah, no, so just that's just my experience as a parent, that there was somebody who was advising us, but we had to really sort of dig around to find out what was the best food. And even though when they're on the peg, they have a sort of, you know, it's a very balanced thing that makes them put on weight. We still wanted him to have the best possible food. And so we ended up sort of blending our own stuff at home and just wanting to put what we felt was a balanced and nutritious food inside his body when he was at his most sick. And also on the wards, you know, it's very complex, obviously, with the chemo side of it, because you've got some children feeling very sick. And so there's cooking, which goes on, which is really upsetting for other children. And then obviously there's other children who want to eat burgers, and then there's parents who want their children to eat better food than burgers. So it was just, I found it very complicated, and we ended up very much taking over ourselves and doing our own thing. and not being led by the hospital, apart from obviously the balanced, nutritious stuff that was sort of fat building that they wanted him to have through the peg. So we followed that, but the rest we tried to do ourselves.
I think that's an excellent example, really, isn't it, of sort of thinking about that complexity. And I mean, hopefully from everything I know from Kathy and the team and the way that they're sort of thinking about food already, it is about having that flexibility, because I think the one size fits all, you know, doesn't work. I think when you've got such complex needs, and there is that kind of therapeutic and nutritional reason for feeding in a particular way versus all the social norms and the sort of tensions between what the child might want, what the family might want, what clinicians might want. But I think, you know, I think being upfront about this and us tackling this head on, which is why I'm so thrilled that Kathy asked me to get involved, you know, from the start on this, because I think the more that we talk to each other and take account of all of those experiences, and that we do take account of parents and what children themselves want as well, then the more able that hopefully we can do that, and be really clear on when we can't do it for good reason. You know, I think it is that transparency and everybody feeling they've got some control over the process. Again, especially if a child that's in hospital or being treated for a long time, you know, that's not easy for a whole load of reasons, especially when there might be other siblings and other people within the family that have got competing conditions or reasons for eating in a different way. So, you know, that this is exactly the sort of conversation we need to keep having, I think. And yeah, I see that in the chat about the options, about this is something we really have to address, you know, and I don't know how bold the Trust and Cambridge Children's wants to be, but, you know, why would we want Burger King on site? You know, for all the reasons I talked about, in some cases, it's quite often a socially acceptable food to eat for lots of reasons, part of people's identity, and it might be very comforting. So we need to do that. But the commercial determinants are so powerful. I think that's another really, really complex thing that we're going to need to talk about a lot, how to get that right. And again, I think we need to consult with parents, families, and the people who work at the hospital who will also be buying food, and the pricing of such food, etc. And yeah, difficult to tell a poorly child they can't have Burger King. Absolutely, that's, you know, that's it, isn't it? It's really difficult. Yeah, and the cost that someone else has pointed out. I think
I was wondering how long before we'd hear about Burger King, and actually it's within the first hour. So I'm glad we've got that one out of the way, because it was inevitable that it would come up. We've got a question here about, could you elaborate, Wendy, please, a bit further on anchor organisations' roles?
Yeah, I think this is all part of this sort of whole systems framework almost. It's seeing an institution that's large, you know, whether it's a university or a hospital, etc., as not being, you know, a standalone functional thing. You know, it is part of a much broader community. I mean, I have the same conversations when I'm talking about supermarkets, actually, that it's not just a commercial place where we all go and buy food. It's part of a community. And, you know, it needs to be seen within that broader sort of holistic sense. And I think as a big employer and a big place that people will go to, whether it's because they work there or because they're being treated there, we really can't see it as a siloed identity. So it's about really thinking carefully and sensitively, and with a sense of, you know, corporate and social responsibility and accountability of how that as an organisation can really do good beyond when people are physically in it, whether they're working there or being treated there. Again, everybody goes back home, whether you're, you know, a member of the workforce or a patient or a family. You know, it's not distancing that. It's, and thinking, when I talked about, you know, do we only want to see children at the moment they're in the hospital, or do we want to think what they're eating and what impact we might have on them when they go back home and go back to school and parents go back to work? You know, it's sort of seeing it as part of that whole mesh of what we're doing across the east of England, which is, again, is really difficult to do, but this is the right stage to try and get that mindset changed towards being an anchor.
Yeah, I think that's a incredibly important point, and it does require a kind of mind shift in terms of how we to date have acted in healthcare organisations. And in fact, we were challenged very early in the project by Peter Fonagy, who leads the Anna Freud Centre in London, when he said to us in one of our first meetings, what's your social contract with the region? you know, what are you doing for the child who's, you know, 50 miles away and living in impoverished circumstances? So, you know, this isn't just about the children coming to the hospital, it's what we're doing for the broader community. And I think having that guiding principle is enormously helpful, as you say, at this stage. So Wendy, it's just nearly 10:15. So I think what I might do now is hand over to Tamsin, because people have a chance to ask Wendy further questions in our panel discussion later on this morning. And we've got a few other people who are going to talk to us before that. But thank you once again. We can't clap anymore, so you don't hear all the applause, but it was a superb talk, and it's one I'm going to be listening to on the recording again as well. I thought it was just